So, and then the foundational attribute, and I know a lot of you are dealing with this now, particularly if you're getting ready for meaningful use or you've already gone through it. You know, a focus on the patient is being foundational was also a key attribute of high-performing organizations. So how does this translate into what's needed and all the work that you're doing on the ground right now? Well, the first thing, and the driver, the most important thing that I hope you'll walk away with today is none of this can happen unless we have a strong IT foundation. You can't do this on paper. You can't move into these new models of care if you're still on paper. And so it may seem really hard some days, going to work, I'll move it down here, some of the changes and the implementation challenges, but it's really the foundation of where we're going. And those who don't make the investments will truly be left behind. We are positive. We're absolutely sure of that. But I think the key, though, because it's the foundation, there's a flip side to that. So number one, the investments are really important and you have to get there. But number two, if you don't get it right, it hurts your organization's whole strategy around improving quality, safety, and efficiency. So it's really important. So gotta do it. And also, if it doesn't work well, bad things can happen and you can't get to where you wanna go. As we get into the health IT discussions, if something doesn't resonate with you or you wanna talk about it more, please raise your hand and let's get into a discussion. So, how does health IT play a role in all of this? We already covered most of it. On the leadership side, you need the data. Access to information requires not only installing the health IT systems that you're focused on, but getting the information to move. And I know, gosh, as a country, we're not so far with that yet. Timely access to care. We're doing a lot of work around online care and connected care. I don't know how many of you are involved in telemedicine yet? Got 1, 2, 3. So still, that's another thing. I think it's coming. I really do. And I know we don't have time to talk about that, but I'll tell you, a lot of the folks in the telemedicine community were talking about it before, talking about it year after year. I'm seeing sort of my radar, the legislation that's being introduced, the number of employers and health plans who are jumping on board, big ones, right? I think we're gonna get there. And the reason we're gonna get there is as we move to payment towards outcomes, instead of doing more reimbursement for visits, it's a way to get access to your rural communities, folks, and to do so at lower cost. And it improves outcomes. Again, the access piece, if you can get in early before things get bad, you can really reduce those healthcare costs. So that's my second prediction. I think you're gonna see a lot more of that. And I think we finally have the political will to get that done. And some of the barriers out there, which if we had more time we could talk about, I can see some softening in some of the issues around online care or telemedicine. Okay, and then of course, health IT plays a role in these other two areas. I want to get to some of the more. So we laid this out and then we looked across the country and we said, okay, if we need health information exchange for care coordination, if we need more engagement of the patient, right, in order to remember the behaviors piece is a big piece of this. It's not just if you deliver care better, it's whether the patient is doing the things, coming in, doing the things that they need to do to improve their health, we won't get to the outcomes. So we looked out across the country and we still have some gaps. So if I had like a lot of ups in my talk about how important this is the part where we hit reality and look at, where do we need to do some more work? And I know here in Georgia, you're doing a lot of work in the key areas here. I know because I was telling you I spent a lot of time in Georgia. One of the things I did, I don't know if Kelly's here, but we did some interviews and did a case study with the National Governors Association on your health IT strategy. So I learned tons and tons about what you're doing. So let's talk about these policy barriers before we wrap it up. So misaligned incentives, we're still predominantly paying for health care, doing more, paying more, but we are seeing a lot of movement towards accountable care. So what I'm talking about doesn't sync with the slides, but I'll quickly, the federal government is investing a lot. The health plans are saying, we're going here. And all of them, WellPoint, United, Cigna, the Blues, are all moving forward on supporting these new models of care. We are going to need some legislation probably. CMS will tell you if the CMMI pilots work, then we don't have to go back to Congress. But I think we're going to need to see some legislative action there. And there's been discussion about SGR and the like. So that's the first thing. The most important thing that will drive all the things we're talking about is if we change the way we pay for health care. The second is information sharing. And actually, we've gone on record a lot, created a lot of ruckus around the lack of information sharing in our country here at the Bipartisan Policy Center. And we're not where we all want to be in a better place, but we're still not there yet. Only 30% of hospitals in our country and 10% of ambulatory practices are participating in operational exchange efforts. There are lots of different data points. None of them are comprehensive, actually. So let me ask, how many of you who are affiliated with a provider institution are exchanging data with someone unaffiliated with you? Not very many. Okay, so your numbers sync with the national data. Okay, so we're not close. And there are a whole host of reasons, one being the lack of alignment of incentives for outcomes, which will drive information sharing, and a whole host of other things. And this, maybe we want to spend some time talking about this. These are really content-heavy slides. Let me just give you the upshot. How many of you are involved in meaningful use implementation? Okay. Really? How many of you are involved in meaningful use implementation? There you go. 20%, maybe 30%. There are a lot of members in Congress right now, on both sides of the aisle. I actually testified in July to the Senate Finance Committee, Energy and Commerce, Ways and Means on the House side. Lots of folks asking questions about why we're not doing more information sharing. Because you know what? That $30 billion that we're investing, all those studies that talked about how you save money in health IT, I'll tell you, if we don't share information, we're not going to realize a lot of those savings, right? I don't think those numbers are going to score, because remember, the whole point about health IT is driving that care coordination, bringing costs down and improving quality, and it's hard to do in a silo unless you're with Kaiser or an organization like that. So this is really, really important. Meaningful use is helping a lot, somewhat. Stage 1 didn't have much in it, either for vendors or providers around information sharing. Stage 2's got more, a lot more. Let me see. Oh, look at this. So, who's with an EHR company in the room? Oh, we don't have any EHR companies. Oh, interesting. Hooray. So, well, you probably know you've got developers at home who are working like crazy getting ready for stage 2 if they're not done yet. Stage 1 EHR companies had to use standards, a handful on this left-hand side, not that many, see 1, 2, 3, 4, 5, 6. Oh, there we are. Had to be able to receive, display, create, and transmit a summary of care record that included these types of data. And the little asterisk means, and you had to use standards. Well, look what they need to do on the right, effective, what's today? September 26th. In about 4 or 5 days, October 1. So EHR vendors who want to get certified, you got to get certified in order for anybody who goes for meaningful use incentives to buy your product, need to be compliant and enable the exchange using standards of a lot more data. And this is goodness for us. We want this to happen. So we were really excited about this. You know, stage 2 doesn't have very many robust requirements. Information sharing, consumers going online. Again, for those of you involved in stage 2, are you tearing your hair out on those? Consumers will be able to view, download, and access their health information from your systems, giving you a headache? Not yet, I'm hearing over here. Well, really important for all of us, right? Who would have thought? I can't view, download, or transmit my health information as a patient? Well, usually not. But stage 2, and we're glad to see this. If we're going to spend federal money on health IT program, we think it's pretty important to help patients download their information. And you know why it's also important? Let's say this exchange strategy doesn't work. It's our, what do you call it? It's our backup plan. It would be, some say, at the end of the day, this exchange stuff is only going to happen if all of us as consumers, as people, start driving it. And whether it's with our USB stick or our consumer applications can start exchanging information. I hope that's not the only way, but really important. So in the interest of time, let's see, talked about EHR adoption rates. They're going way up, but there's been, I don't know, if you read email and all the news blasts, there's a lot churning right now about it's too hard, we can't do stage 2. You know, a lot of the associations are calling for some delays, and the about 13 Republican senators also called, not for a delay, but for an extension of the amount of time that providers will have to comply with stage 2. And I'll tell you, there's been a lot of discussion about this. It's not because people don't think it's the right thing to do. I think particularly in the rural areas, and tell us if you concur, in some of the rural areas and the small community hospitals and physician practices, folks are struggling with some aspects of stage 2. They're not going to get there. So we don't want to leave people behind. We've got to find ways to make that work. So that's the conversation that's going on right now. I know CMS is looking at it. I'm not sure where they'll end up. I think we're still starting. We're definitely getting started on October 1. I think there's an open question as to whether they'll give you more time on the back end in order to comply. For all of you that are spending a heck of a lot of time, whether it's 40 hours a week or 120 hours a week, on making these systems work, it's really, really important. It's not just a health IT system. You're actually laying the foundation for all the changes that need to happen to improve quality, reduce costs, and improve in our healthcare system, and very importantly, improve the patient experience of care. Not only is it the right thing to do, it's going to be required in the future in order for whether you've got private payers, Medicaid or Medicare, they're going to require you to get there as well. So there's a business imperative to what you're doing, but there's also a moral, really important imperative for all of your work. So congratulations to all of you who are spending a lot of time in this area. It's really important, and I really enjoyed having an opportunity to share some of our insights. So I think we've got a couple of minutes. Questions? Something I say not make sense? Do you vehemently disagree? Any questions? What about this stage 2 meaningful use? I knew we had some CIOs this morning. How's it going? Do we need a delay? Or should we stay the course? Gentleman says delay.
For the summary of care is rather daunting with a lack of interoperability between systems. And establishing how to do that is quite a challenge. And if you fail one measure, you fail meaningful use. And that's just one of the many measures that we have to meet.
So it's the chicken and egg, right? So the providers are saying, don't make me share information if the vendors aren't going to let me do it, right? It's the pointing fingers piece, or that their systems aren't interoperable. My vendor won't share, so don't hold me accountable. I think that's what some folks are saying. But it's tough from a policy standpoint. Do you do a sequencing? There's only so much money, and then we move to penalties. But that's a big thing that keeps coming up. What's getting in the way of information sharing for you all? Is it technical? Oh, thank you.
ONC recently made an announcement that they're forming, for better safe word, a committee between CHIME, HIMSS, AHIMA, to address the issue of patient identification and accuracy and governance of data within source systems. To be able to share information, you have to have an accurate representation of a person. And what I find is systemic within this industry is that on average you have anywhere from a 5 to 10% duplicate rate of patients within hospital information systems and providers. And most of the IT organizations don't have any way of measuring the false negatives, meaning the duplicate records that their system, their in-house system can't identify, which leads to the duplicate record rate. So what can be done as an industry to address the missing information that most CIOs and IT organizations don't have with regards to bad data?
I'm glad you raised that issue. Actually, I didn't talk about it in my talk, but the Bipartisan Policy Center convened a number of groups, including CHIME and HIMSS, and issued a report calling for this, and we're pleased that HHS carried out the recommendation in our report. We're actually involved in that effort. It's really led by HHS. They have to be careful. They're going to get input from a lot of groups. We're going to do a briefing for folks on the Hill later this next month, because I think this is going to be a tough road. There are a lot of folks that want it to happen. There are some folks that don't, as you well know. But in our report, and it actually aligns well with Lee Stevens' scope of work on this HHS work, I don't think we're going to get to a unique patient identifier. I don't think that's even going to solve the problem, many say. But what I said to Lee is if you could get agreement on 7 fields, right? And we had a lot of CIOs. Bill Spooner was involved, Neil Ganguly, Randy McLeese, and others. CHIME did a survey in conjunction with our report where we tested false negatives and false positives. You know, the error rates are pretty high, but our sense is if we can at least get to agreement on whether it's cell phone number, what demographic information, and then as an industry, both government, the CIOs on the ground, physician offices could agree on always collecting those 7 elements, or 5. I know people are debating that, and to use standards. You know what? Even for the ones that are most often cited, we don't have standards yet for all of them. I think we can go a long way and do so. The other policy, so I think Lee is going to look at those 7 attributes. They're going to use some of the health IT policy work. And then I think it'll be, if I were driving this, you get agreement, you bring consumers to the table, you make sure people feel comfortable, you make sure the Health IT Standards Committee adopts standards in those areas, and then we build those in the development cycles of every EHR product, every other clinical software system, right? Because it's not just EHRs. And then hospitals, in particular, and physician offices agree to implement, and then we can get there. Other ideas that folks within the administration have batted around is this notion of consumer-directed. looking at NSTIC. But huge issue, and one that comes up not just for delivery, but for improving population health. Thanks for raising that.
When you look at that list of highly performing organizations, one of the hallmarks is the fact that they tend to have more efficient care for Medicare patients, lower per capita costs. In light of that, one of the bits of information that we would need to be able to evaluate the recommendations of your committee would be, what is the financial component behind that? In other words, obviously they have a lot of technology in place, they have a lot of analytics in place, they have a lot of resources in place to be able to perform at this level. How do they finance that? In other words, are we really comparing apples to apples with the average organization in the country, or is there a huge discrepancy that's hidden in the financial components of that organization?
That's a great point. And we didn't look at that. We did not. I mean, we looked at outcomes, quality and cost outcomes in healthcare in order to determine who to interview. And then we asked them questions. But one thing that came up, you'll see if you look at the list, and I'm having trouble going backwards, we wanted to be sure that we interviewed a wide range of organizations. But I'll tell you, we couldn't identify that many in the smaller category, which raises a whole host of other issues. And as I think about information sharing and all of the things that we're talking about today, I spend a lot of my time with small physician practices. You know, I wonder, and maybe this is a market thing versus a policy thing, you know, to date, like, how do we help smaller organizations that don't have the capital, that are just living year to year, particularly these physician practices, to make these investments? And I think we had some early investments in the regional extension centers. A lot of the grant programs are going away, but there's such a demand. Any other time as a country where we've had big demand and a market, the market comes, a cottage industry pops up and fills the market need. And I'm hopeful something like that will occur. There are lots of folks that are going to get left behind if we don't figure out how to help them, and whether it's group purchasing or if there's a market there. But it's not a market for everyone. The margins are smaller, it's hard, you gotta send 2 bodies out there, it's pretty far, and your revenues aren't as great, like all of those business things, but I'm hopeful that the market will step up. Any ideas? No, I'm sure. This is a great cottage industry, especially when they start changing the way. We're probably going to be, I see the gentleman from CMS there, we're probably going to be talking a little bit about payment later. All right. Well, thank you. It was a great pleasure to be with you, and enjoy the rest of your day. Thanks.